Good evening, our esteemed attendees of today's meeting. Good evening, members, esteemed members of the Pharmaceutical Society of Kenya. Good evening, my esteemed colleagues at PSK. Good evening, our senior respected members of the Pharmaceutical Society of Kenya. And once again, good evening, the honorable fellows who are joining us from PSK, and our wonderful visitors for today, Dr. Florence Keli and Miriam Washira. Good evening. Welcome to today's meeting. Today's virtual CME is in partnership with Boehringer Ingelheim. And it is, the topic on today is on SGLT21, and it's mainly an abroad impact therapeutic option in type 2 diabetes management. I will begin the meeting the closest we are at 250, or the closest we are to 2705. In the meantime, let me know where you're joining us from. Allow our respected speaker for today, and probably our sponsor for today, to know where you're joining us from. On the chat box, kindly write for me where you're joining us from, probably your cadre, if you're a pharmacist, if you're a pharmaceutical technologist, if you're a medical officer, if you're a clinical officer, just type in pharmacist joining in from Nairobi County. This is where I practice. Kindly let us see where you're joining us from on the chat box. Thank you so very much. Welcome, Dr. Jitesh from Meru. Dr. Wilson Mageto, Jack's Pharmacy in Kisii Town, karibu sana. Madam Angela Dirango from Narumoro, karibu sana. Wonderful. Welcome so very much, Dr. Catherine Mambura. Miriam Omwenga from Kuwait. Welcome so very much to today's meeting. Matthew Otiambo from Bondo, karibu sana. Jane Papai from Busia, karibu sana, the border county, border town. Kipkoech from Kilifi counties, welcome so very much to today's meeting with Simon Ciele from Sychem Pharmacy in Kericho. Welcome so very much, our respected senior Dr. Zakri Hussein, registration number 842 from Malindi town. Dr. Nadia Bat, welcome so very much from Nairobi County, and that is Health Aid Pharmaceuticals. Wonderful, wonderful. I can see we have surpassed our number, 250. So without further much ado, allow me to kickstart our meeting. As I usually always say, is that I'll have to start the meeting when we get to above 250 members. And as we're beginning our meeting, I want us to just, on the chat box again, what advantage do you know of SGLT2 type of drugs? Just give us an advantage of the SGLT2 inhibitors on the chat box. One advantage that you know about it, about the type of drug we are just about to speak today. On the chat box, what advantage do you know about this drug or this family, this class of drugs, SGLT2 inhibitors? Just give us one advantage that you know about it on the chat box. Thank you so very much, Dr. Albert Ndwiga, Family Planning MOH. So allow me to take this wonderful opportunity to welcome you to today's meeting. This meeting is in partnership with the Pharmaceutical Society of Kenya and Boehringer Ingelheim. It has been sponsored by Boehringer Ingelheim. The meeting is basically on a topic on SGLT2 inhibitors, a broad impact therapeutic option in type 2 diabetes management. Our wonderful speaker for the day is none other than Dr. Florence Keli, an endocrinologist, diabetologist with the University of Nairobi. The meeting is CPD accredited by the Pharmacy and Poisons Board. And I'll go through a few ground rules before I begin. First and foremost, I'll say thank you so very much for participating in this session. But all participants are muted during the entire course of the session. Please ask the questions via the Q&A tab at the bottom of the window. Questions should be addressed by presenters on the Q&A tab. For all members, if not already done so, please subscribe. Today, all members in the pharma sector will be awarded the CPD points. Please subscribe to the CPD point on the PPB portal, that is page 15. That will be well taken care of. A point to note is that this session is being recorded and will be made available on PSK's YouTube page. Also receive the greetings from the PSK president, none other than Dr. Louis Mashoku, and also the CEO PSK, Dr. Lucas Nyabero. In the meantime, before I introduce our speaker, I'm asking a question. What do you know on today's, what is the advantage of today's class of drugs that you know? I can see Dr. Ahmed Abdikar says it's renal protective action is one of the advantages. Cornelius Luyanje says it's mild improvement of lipid profile. Keep on bringing in these advantages of this drug that you know. So let me go to the next page. That is probably our agenda for today. And our agenda for today is welcoming remarks, which has been done by myself. Then we go directly to the meet, and I'll stop sharing my screen as I allow Daktari to share her screen.
Thank you.
Karibu sana Daktari. Ladies and gentlemen, without further much ado, allow me to give our speaker of the day this wonderful chance to take us through what she has prepared for us. Probably she has been able to look at the chat and seen what people know about the SGLT2 inhibitors for tonight. Dr. Florence Keli, karibu sana Daktari, take over.
Bao, could you please minimize the toolbar at the top so that I'm able to see my toolbar?
Daktari, click on the top right. There's a place where you're able to see the slideshow.
Top right.
Top right on the 1, 2, 3 on the fourth tab. On the fourth tab, you're able to see the slideshow. There's a sign of a small play button. That is the slideshow.
Say it again, please. On my top right.
On the top right, you'll be able to see a click, or on the same time on your slide, there is a tab written slideshow.
Okay, the toolbar is barricading. I'm not able to see my toolbar.
Okay, try switch off your video, Dr. Switch off your video, then see if you're able to see it on your end.
Okay, let's see, slideshow.
Can you see it, Dr. Wonderful, Dr.
Okay, so I'm going to start my presentation. As you heard, my name has been said severally. They remain my names, Florence Keli. I'm going to be presenting on SGLT2 inhibitors in the management of type 2 diabetes. And as it is, I've been contracted by Boehringer to conduct this session, and have no financial interest in the establishment. The following will be my slide outline. Prevalence of type 2 diabetes. I'll talk about the prevalence of type 2 diabetes, some science, diabetes and cardiovascular disease, because this is very important. Then pharmacologic choices in the management of type 2 diabetes, because it is not only SGLT2s, but they form part of the management. The mode of action of SGLT2 inhibitors, which I know you all know, being a pharmacist. And then I'll discuss the EMPERAGE study and conclude. Okay. So I'm sure you are all aware that globally, there are 415 million people that are living with diabetes, and this is going to rise to 642 by the year 2040, which is almost a double, maybe a 3/4 increase, quite significant. At least 68% of these people with type 2 diabetes and are more than 65 years of age will die of a heart disease, and that is of a concern. This implies that if one has diabetes, then we have to find a treatment that will not only lower the blood glucose, but also reduce the risk of heart disease and cardiovascular diseases. Now, what are the basics that we need to know? Whenever we talk about atherosclerotic cardiovascular disease, we are either referring to a myocardial infarction or an acute coronary, a coronary syndrome, acute or chronic, that is stable and unstable, coronary heart disease with or without a revascularization, because even when the patient has been treated by revascularization, they remain at further risk of coronary heart disease. Any other arterial revascularization that may have happened, because you may encounter a patient who has had a revascularization of the lower limbs. Then this includes also stroke. It includes peripheral artery disease, which is commonly ignored because we focus on the heart much more and think about myocardial infarction. We should also be focusing on limb loss or leg loss. Then the patients, who are the patients at a high risk of atherosclerotic cardiovascular disease? Those are the patients that have got end organ damage, such as people with a thickened left ventricular, which is common in diabetes, patients with retinopathy, patients with multiple cardiovascular risk, such as the ones who have advanced age, patients with hypertension, patients who smoke, patients with dyslipidemia and obesity. Okay, and then we'll also touch and include a bit of and consider diabetic kidney disease, because which is marked by reduced GFR and presence of albuminuria or both. So I know you all know how SGLT2 inhibitors work, but how does the story begin? We know that for the body to function, we need glucose to enter into our cells. How does it get in? It goes in via facilitative glucose transporters and also via sodium glucose transporters 1 to 6. But our focus today will be SGLT1 receptors. SGLT1 and 2 are located in the intestines and kidneys. SGLT2 inhibitors prevent renal absorption of glucose, causing an anti-diabetic effect. And as I've said above, SGLT2 receptors are located in the kidney, and that is the focus of SGLT2 inhibitors. Okay. We must recognize that people with diabetes are 2 to 5 times have a 2 to 5 times risk of developing heart failure. Okay, whether we like it or not. So as I said earlier, you must always come up with a regimen or a treatment modality that will also influence this effect, the risk of heart disease, cardiovascular disease. And this was established since the year 20, I think it was between 2015 and 2017, where it was declared any other new medication that is going to be developed or discovered for the management of diabetes, and in this case, type 2 diabetes and even type 1 diabetes, but we don't have an intervention that influences cardiovascular disease in type 1 diabetes. But for type 2, we do have SGLT2 inhibitors and GLP-1 receptor agonists. So it was said, in I think between 2015 and 17, that any other intervention must also lower the risk of cardiovascular disease. And as we can see, diabetes increases the probability of cardiovascular death by 60 to 80%. So now, if you look at the chart I'm displaying right now is demonstrating the life pattern of a patient who has got no diabetes. So a patient without diabetes, which is the first bar, will live to the end of life. That is their determined end of life. But a person with diabetes, their life is reduced by 6 years, just when they are diagnosed to have diabetes. And if they suffer a myocardial infarction, their life is reduced by 12 years, okay? And maybe even more. So how do you reduce the risk of cardiovascular disease? We all are aware that we need to lower the lipids, that is manage dyslipidemia, control blood pressure, and use antithrombotic agents, because when all these factors come together, that is when people suffer occlusion of blood vessels, okay? Then we cannot forget that we also need to lower the blood glucose. And always we aim to achieve a HbA1c of about 7 or less, depending on whether the patient is able to tolerate a blood glucose that aims at reducing the HbA1c to less than 7, okay? So the point I want to emphasize here is that do not have a universal target for all your patients. It depends on your patient, because diabetes patients tend to have concurrent disease. And if you lower the blood glucose too low, some of that the outcomes of the comorbidities might be deleterious. Okay. Now, I've been talking about diabetes and cardiovascular disease. When you look at this chart, the pie chart, it's showing us that the cause of death in type 2 diabetes patient is mainly cardiovascular disease. And that is why we must emphasize that whatever regimen that you're going to include in the management of your patients must reduce the risk of cardiovascular disease or manage it, which SGLT2s have. They possess that effect. So this is a very one of my favorite charts in the management of type 2 diabetes. A very important reference point. It talks about it's mainly about what management you will pick for what patient. So mainly look at what is the first option what is the option I first have in the management of diabetes. We always start with metformin unless the patient cannot tolerate or there is no indication for using metformin. Then we go further and think about the patient in terms of, is there established atherosclerotic cardiovascular disease or chronic kidney disease? Or does the patient not have those two, atherosclerotic cardiovascular disease or chronic kidney disease? Let us go on to the left side, whereby the patient has established atherosclerotic cardiovascular disease or CKD. Okay, so adding to the metformin, you will either pick an SGLT2 or a GLP-1, depending on what the patient is manifesting with. And in this case, you'll always pick an SGLT2 inhibitor with a proven cardiovascular disease benefit, such as empagliflozin. Okay, there are many other SGLT2s, but some of them do not have cardiovascular benefits. But the ones that we have in our market do have cardiovascular benefits. An example is empagliflozin. Okay, you could also use a GLP-1 receptor agonist, but that depends on the patient. There are cutoffs such as what is the eGFR of the patient. Okay, for SGLT2 inhibitors, we are fortunate because you can go as low as an eGFR of 18 in the current studies. Okay, let us go to the right side of the presentation. Establish if the patient doesn't have atherosclerotic cardiovascular disease or chronic kidney disease. You look at three aspects. Do we need to minimize the risk of hypoglycemia? Do we need to reduce the patient's weight? And is cost a major issue? So focusing on the compelling need to minimize hypoglycemia, you can either pick an SGLT2, okay? If you had not already considered it, you can use a GLP-1 receptor agonist, a DPP-4 inhibitor, or thiazolidinedione. Thiazolidinedione has many benefits that I will not talk about today, but it's still a choice in the management of type 2 diabetes. Or is there a compelling need to minimize weight? That is when we have two options, an SGLT2 inhibitor or GLP-1 receptor agonist. I commonly like using SGLT2 inhibitors, not to say GLP-1 receptor agonists have got any issue. They are equally beneficial, but remember they are quite costly in our setup, and we do not yet have the oral formulations in our setup, but even the injectables will do over and above their side effects. Then the third arm on the extreme right is cost a major issue. When cost is a major issue, then you can use a sulfonylureas or thiazolidinedione. They still have a role unless contraindicated. Those are the choices we have in the management of type 2 diabetes. And of course, you could always add on insulin. You can start with insulin. You can play around with the options that you have and manage your patients accordingly. Okay, So this is a further emphasis on what you need to look out for in a patient with type 2 diabetes. Aside of atherosclerotic cardiovascular disease and chronic kidney disease, you also need to factor in, is the patient at risk of heart failure? As I told you, diabetes patients are at 2 to 5 times risk of developing heart failure, whether they have got any other, whether they have hypertension or heart disease or not. At one point in the progression of the disease, they will end up with heart failure. So in this case, that is when we emphasize on the use of SGLT2s. As you can see, it is marked in red. Why is it indicated in red? Because of the salutary effects that have been observed in the trials that have been conducted so far, that SGLT2 inhibitors reduce the risk of heart failure. They also they can also be used in the management of heart failure in patients with or without diabetes. So in summary of what I've been saying, choose an SGLT2 inhibitor when your patient has established atherosclerotic disease, which I defined earlier, or is at risk, as heart failure or diabetic kidney disease. And as I said, you can use SGLT2 inhibitors up to an EGFR of 18, and who knows, maybe we can use them until the EGFR is 0. Maybe the future will tell us, okay? You can also use a GLP-1 receptor agonist when your patient has atherosclerotic disease or is at risk, but you must check the EGFR of this patient. If it is less than 60, don't use them. So why are we talking about diabetes and cardiovascular disease? It's because since time immemorial, and the studies that have been done so far, I think the one study that was a landmark was the UK PDS study that showed that when you control blood glucose early, you reduce microvascular disease and make an improvement of macrovascular disease. But all in all, whether you are considering macrovascular disease or microvascular disease, that is cardiovascular disease, okay? So in that study and the studies that have been done so far, there is not much evidence in regards to risk reduction, cardiovascular risk reduction, and glucose control, okay? It is only known that after a patient has been initiated on treatment for diabetes, there is some modest cardiovascular risk reduction after some time, not immediately. And it has also been observed when you are too strict with the glucose control, you have adverse cardiovascular outcomes, especially in type 2 diabetes. So you lower the blood sugar too low, that is achieving a HbA1c of less than 6.5, patients start dying of cardiovascular diseases. And as I said, it was declared by major regulatory bodies since the year 2017. Any new glucose lowering agent in the management of type 2 diabetes must have cardiovascular benefits, okay? The mode of action of SGLT2 inhibitors, they decrease renal glucose absorption. Therefore, they increase urine glucose excretion. And empagliflozin is one of those, okay? It is approved as add-on or even a single therapy. You can assess a patient, and if they are not able, you are not able to give this patient metformin, you could as well start with an SGLT2 inhibitor. inhibitor, an example of which is empagliflozin. It has benefits. What are these benefits? It reduces weight, it reduces blood pressure without increasing heart rate. Why am I talking about this point? Is because GLP-1 receptor agonists will reduce weight. And when you reduce weight, of course, the blood pressure goes down, but they have a tendency to increase heart rate. I'm not demonizing them. They still have a role in the management of diabetes. SGLT2 inhibitors have got additional benefits, such as improving arterial stiffness, which occurs with advancing age and diabetes. And they also improve vascular resistance, visceral adiposity, albuminuria, and plasma urate. And you are all well aware that the commonest side effect is urinary and genital infections, but these ones can be managed and controlled. Empagliflozin is available as either 10 milligrams or 25 milligrams. The prescription or selection or whatever dose is based on the targets that you want for this patient. And these targets are HbA1c, the fasting plasma glucose, the mean plasma glucose, or any other patient dynamics. Depends on what you want to achieve in the patient, okay? Remember, when you pick a higher dose of empagliflozin, then there's a higher chance of the patient experiencing the adverse events of SGLT2s. So, why SGLT2s in the management of type 2 diabetes? Okay. The trials that we've been having have been showing different things. For example, trials that were done with DPP-4 inhibitors, they were neutral in regard to cardiovascular events, the major adverse cardiovascular endpoints. Usually you look out for stroke, myocardial infarction, you look out for cardiovascular death or death due to any cause. So DPP-4 inhibitors neither reduce the risk of all of these adverse outcomes, neither were they worse compared to placebos, okay? And this was the beginning of a trigger for a drug that would have an influence on cardiovascular disease, okay? So this forest plot is again about trials on DPP-4 inhibitors. In fact, in the SAVA team and examine trials, it was demonstrated, as you can see in these two plots, that DPP-4 inhibitors may not be favorable in patients with heart failure, okay? But that does not mean that you don't use them. They still have a place, especially when cost is an implication, okay? This is a trial on GLP-1 receptor agonists. As I have talked about them previously, they still have a role in the management of type 2 diabetes. However, there are some factors that you must check, such as the eGFR and patient's heart rate, because they have been known to increase patient's heart rate, even though they have cardiovascular benefits, as we can see, okay? When in the ELIXA, LEADER, SUSTAIN, and EXCEL trial, these drugs showed cardiovascular benefits in these trials. So they still have a role in the management of diabetes patient, and then consider the caveats, okay? EMPA-REG was a trial that was conducted in 42 countries, quite a huge trial. So many patients were screened for participation, 11,000, and 7,000 patients were randomized to placebo or empagliflozin 10 or 25 milligrams, okay? What was the trial design? So the patients were screened, 11,000 of them, and then out of these 7,000 were picked to participate and randomized to either empagliflozin 10 or 20. And these drugs were given over and above any other intervention that the patient was using for the management of diabetes. Patients were not only on placebo or EMPA 10 or 25. This was in addition to what the patients were taking, okay? And this was a double-blind study. Nobody knew whoever was taking what, okay? And if an event occurred, there was an independent team to evaluate the outcomes of the study, whether good or bad, okay? What was the inclusion criteria? Adults with type 2 diabetes, BMI of less than 45, HbA1c between 7 and 10, and patients with either a prior myocardial infarction, coronary artery disease, stroke, unstable angina, or occlusive peripheral arterial disease, okay? Patients with eGFR of less than 30 were excluded, but it has been established that these drugs can be used at an eGFR of 18. So this information has been superseded as at now, okay? What were the outcomes? What were the study outcomes? The primary outcomes was a composite of time to first occurrence of cardiovascular death or non-fatal myocardial infarction or non-fatal stroke. And then important secondary outcomes included considered individually time to first occurrence of cardiovascular death or non-fatal myocardial infarction, non-fatal stroke, or hospitalization for unstable angina, okay? Other outcomes were cardiovascular death, non-fatal myocardial infarction, considered individually, hospitalization for heart failure, all-cause mortality, and all cardiovascular and neurological events. They didn't matter which one, whether they were independent or discussed by the client, it didn't matter. They were included, okay? And those are the countries that were participated. Fortunately, we were not included, as you can see here. We are there, but doesn't mean that we don't use the medication. So the characteristics of the patient, just for ascertaining and showing the authenticity of the trial, is that the patients were well matched. You can see in the placebo, in the 10 milligrams and 25 milligrams arm, the patients had they were similar. Even the male to female ratio was almost equal, okay? And the other agents that the patients that were using for the management of diabetes included metformin, sulfonylureas, DPP4 inhibitors, diazolidine, dione, and insulin, over and above the use of the study drugs, okay? And I said patients that had a BMI of less than 45, and as you can see, the patients were matched, okay, during screening. Even their baseline characteristics of blood pressure, lipids, and renal function, they were all approximately the same. They were similar, okay? Baseline characteristics further, coronary artery disease in these patients similar occurrence in all the groups, and any other disease in relation to cardiovascular disease was similar in the 3 arms of the study. Okay. What were the lipid lowering drugs that were used in this study? Patients, majority were on statins, which is expected, and a few were on fibrates. Another small amount was on ezetimibe, and other patients were on other agents not otherwise specified in this slide for the benefit of lowering lipids. And then they were also on anticoagulants such as acetylsalicylic acid-based anticoagulants, clopidogrel, and vitamin K antagonists. Remember, we said that if you want to lower cardiovascular risk, these are the agents that you need to use over and above blood glucose control and lowering blood pressure. So these were the outcomes of the study. When we look at this forest plot, is showing us the patient's characteristics, and in terms of demography, the HbA1c, and BMI, the eGFR of the patients. So when we look at it intently, this empagliflozin favored patients with, in terms of reduction of cardiovascular death, because on this side is empagliflozin favoring less cardiovascular death, and this other side is not favoring cardiovascular death. So empagliflozin reduced cardiovascular deaths, and this benefit was more in patients who had an eGFR of 60 to 90. But as I said, we can use these drugs in patients with an eGFR of up to 18. So in terms of adverse events in regards to empagliflozin compared to placebo, I'll quickly go to the expected adverse effects like urinary tract infection. As we can see, the outcomes were similar. There was no difference between placebo and empagliflozin. So that's not anything to fear occurring in patients. Genital tract infections, we expected them, of course, to be more with the empagliflozin arm. So we can appreciate that in the placebo arm, there were less genital infections, but in empagliflozin 10 and 25, genital infections occurred, but these can be managed. And when patients are given proper instructions, then the other risk you worry about when you bring in a new drug for the or you're prescribing for management of type 2 diabetes and even diabetes is hypoglycemia. As you can see, empagliflozin does not cause hypoglycemia. You also worry about major organs, liver injury. Empagliflozin was favored. And then worsening renal function, empagliflozin actually improved, okay, time to end-stage renal disease. And then the other worry, because these drugs cause glucose excretion in the kidney, you worry about volume depletion. So empagliflozin 10 actually was similar to placebo in terms of volume depletion. But 25 milligrams, a little more cases of volume depletion. Remember, I said that your targets for the choice of strength of empagliflozin must relate to the patient in terms of what are you seeing in the patient and the target. And I say that the higher the dose, the higher the likelihood of occurrence of adverse events. Then hypersensitivity to empagliflozin, nothing to talk about. Bone fractures, SGLT2s have been shown to have a tendency to cause bone fractures, but not all of them. This was an observation seen with canagliflozin. As you can see, the occurrence of bone fractures was basically the same in the 3 arms of the study. Then because volume is depleted, you also want to know how whether there was occurrence of venous venous thrombosis. As you can see, as it were, 10 milligrams of empagliflozin even had less DVT cases. Then in regards to adverse events occurring with the empagliflozin, when you look at the rates between placebo, empagliflozin 10 and 25, these figures are similar, okay? There was not a marked difference. And then the other thing you want to worry about is whether the adverse events will occur more in the female or female. As we can see in this case, the genital infections and urinary tract infections tended to occur more in men, and there's no explanation to that. Maybe men are likely not to observe hygienist too. I don't know, that's a speculation, okay? In regards to major adverse cardiovascular events, remember I talked about cardiovascular death, a composite of cardiovascular death, and then fetal myocardial infarction or stroke. Empagliflozin was seen to have a reduced number of patients with these events compared to placebo. Okay, that is straightforward. And then a comparison of placebo, EMPA-10, EMPA-25. There was no difference between EMPA-10 or 25 really. And as I said earlier, your choice of strength depends on what target you want to achieve with your patients. Okay. In regards to the major adverse cardiovascular events, empagliflozin reduced, whether 10 or 25, reduced the major adverse cardiovascular events, as you can see from this forest plot. You can see it reduced the composite of 3 adverse events. It reduced cardiovascular death, it reduced non-fatal myocardial infarction, and although there was a tendency not to favor non-fatal stroke. And this, I only speculate, could be due to the volume depletion. As it is, there is no scientific explanation, but you could say that because they reduce volume, maybe the blood becomes too viscous and tends to lead to strokes. Okay. In regards to cardiovascular death, empagliflozin reduced cardiovascular deaths in the patients that participated in this trial. And then the other significant effect and advantage of empagliflozin was reduced time to heart failure, and that is the incidence of heart failure, the hospital stay, and death to heart failure. So empagliflozin favors that. Also favored all-cause mortality, whether 10 or 25. And then the composite all-cause mortality, cardiovascular death, and non-cardiovascular death. Empagliflozin favors, as you can see that the confidence intervals in this forest plot are on the left side of the line of neutrality. Then there was an analysis in regards to the number needed to treat to prevent major cardiovascular events. If you are only to intervene with simvastatin, you needed to treat 30 patients, okay? And if you are only going to use, and that would take 5.4 years to reduce the risk of cardiovascular event. If you are to give ramipril, reduce the cardiovascular risk, you need to treat 56 people for 5 years. And with empagliflozin, you need to treat 39 years for 3 years, quite less than the others. Okay, so it's a favorable drug. You only need to treat a few people within a short time, and the benefit will be, cardiovascular benefit will be observed, okay? In regards to worsening of renal disease, okay? The placebo, of course, tended to worsen renal disease compared to empagliflozin. Actually, in the renal studies, empagliflozin, SGLT2 inhibitors reduced the time to worsening of estimated glomerular filtration rate. So these are good drugs because we know in our mind, you must bear that a patient with diabetes is at risk of microvascular and macrovascular disease, okay? Macrovascular disease, we've talked about stroke, myocardial infarction, peripheral artery disease. Microvascular disease includes retinopathy, nephropathy, and yeah, those are the main ones, okay? So when you're giving an intervention to the patient, always think, what is my influence in regards to macrovascular and microvascular disease, okay? And as I've said, empagliflozin increased the time to initiation of renal replacement, such that if the patient was going to get to end-stage renal disease within a year, that is increased maybe to 4 or 5 years, okay? And then it also improved the risk of death due to renal disease, and also reduce the rate of doubling of serum creatinine. And then in the empagliflozin arm, the risk or the incidence or worsening of renal disease was less in the empagliflozin arm. And overall, empagliflozin, if we follow the line of empagliflozin, you can pick the 10 and look at worsening of reduction of eGFR. In the placebo arm, eGFR continues to decline, while in the empagliflozin arms, whether 10 or 10, it actually improves and then remains stable. Okay, that's the same thing. Okay. In regards to acute renal injury and acute renal failure, again, empagliflozin is favorable, despite the fact that it causes volume depletion. And then considering doubling of serum creatinine, initiation of renal replacement or death in patients with who at the beginning of the study had macroalbuminuria. Empagliflozin actually improves the status, the renal status of a patient with macroalbuminuria. And as you are aware, this is like an additional improvement to when you give an ACE inhibitor or an ARB. So you further make the patient's life better and clinical condition better. Conclusion: empagliflozin reduce 3-point major adverse cardiovascular endpoints. It reduces the worsening of established renal disease. It also reduces the incidence of new cases of renal disease. Thank you. Over to you, my host. Hello, am my host still with me?
Yes, Dr. I'm here with you loud and clear. Thank you so very much for the wonderful presentation. Allow us to probably now go to Madam Miriam. Miriam, are you there with us?
Yes, I am. Thanks,
I stop the share?
Yes, you can stop the share. And for attendees, I first want to recognize the presence of a senior respected member, Dr. Arti Kamau, Dr. Evangeline Maina, and also to recognize the presence of the chair, Nyanza branch, that is Madam Dr. Irene Olweni. Karibuni sana. So in the meantime, as Miriam is sharing her screen, I've pasted a link there. Kindly click onto that link and share with us and tell us what you find, and give your feedback on that link that I've shared with you there. Thank you so very much. Miriam, over to you.
Okay, thank you, Mbao. I'll be very fast because of time, so that I can see Q&A is quite busy, so that we can be able to handle. So my name's Miriam Washira. I'm the Key Accounts Manager in Boehringer Ingelheim. For me, I'll take you through the pharmacoeconomic evaluation of Jardiance in management of type 2 diabetes. So mine will be more value versus cost. I think Dr. Keli has talked about the science. So she mentioned this, the life expectancy, what is the impact if a patient is diabetic and then diabetic with probably cardiovascular disease. So of course the life expectancy reduces with 6 years with diabetes only, and then with diabetes with the comorbidity of cardiovascular disease reduces with 12 to 14 years. My aspect here will be, what are the cost drivers in diabetes? So this was a study that was done in the UK. Just once we look at the direct cost of the drug only, it is that people tend to ignore that actually in the long run increases the cost of managing a diabetic patient. So as you can see on my table, there is, of course, if the patient has progressed to complications, that is heart failure, neuropathy, retinopathy, and all that, it increases the cost of managing diabetes. Of course, hospitalization due to diabetes or hospitalization due to heart failure. So that contributes to excess bed days. Also, that contributes to the cost of diabetes. Of course, the general management in terms of lab tests, all these hula baloos that come in also increase the cost of diabetes. So what are we saying? Heart failure is very expensive. It's a complication of diabetes. So if this patient is not well controlled, the blood sugars are not well controlled, and they start progressing. Of course, the first time that diagnosed with heart failure, of course, most of the times this patient will be admitted to HDU, and you know how much it costs to put in a patient in the HDU and all that. Well, how can we prevent this? And that's what I want us to discuss. If this patient is initiated on the right medication initially, can we prevent this cost and also improve their quality of life? So it's an important and a recognized complication of diabetes, that is heart failure. And I think it's something that now it's becoming more vocal. People are talking about it. What's the cost of treating heart failure? You know, in the decades to come, it will be expected to be very expensive if this patient is diabetic with heart failure and all other complications that come in with uncontrolled blood sugar. But can we prevent this? You know, let's not just look at the direct costs of the drug, because most of the times you have this discussion and how much is it? Okay, will the patient afford? But who dispenses, you as the person will have this intimate discussion with this patient just to understand, as you explain to them the dosages and what exactly this drug is going to do to their, you know, their body. Can you have also, it's just my recommendation, can you also make them understand the reason why the consultant or the doctor has put them on this? It's because, you know, they are saving up on this, they're preventing them to progress to, and just the other day, we had all this discussion with NHIF, cutting down on dialysis, cutting down on certain costs. So you can imagine if this patient is not well controlled, just to give them some, is the assumption it's controlling the sugar. But little do we know that it will progress. The sugars are not well, and if NHIF is not going to take care of it, what happens to this patient? It will be very unfortunate. But if this patient, you have this intimate discussion and make them understand the reason why the doctor feels that you need to be on this is to, you know, delay progression to renal impairment, delay progression to any cardiovascular disease because you're already diabetic. So this makes the patient understand why it is important to incur this cost now to prevent more expensive costs that they will incur in the future. Just, you know, the way you cushion yourself, you know, we are used to this savings plans and insurance policies, and you do it to cushion yourself in the future so that if you get this, you know, this be able to handle it. It's the same thing. Of course, for now, it feels a pinch to, you know, cheap your future. It's the same thing with when you're considering this cost of Jardiance now, when the patient has been diagnosed with diabetes and they've not progressed to any complications. If you cushion them now, of course, you save them up so much in the future, cost of complications, which you're going to see a very good table in a duration of 6 to 12 years. And of course, quality of life of this patient also improves. And it's, anyway, it also saves up for institutions that take care of their employees together with their dependents. You're able to save up on more budgets when you look at, if you consider having this drug has, you know, it's more expensive, can you get something cheaper? But in the long run, you end up spending more as an institution because now the patients have progressed to complications, they're doing dialysis, they're hospitalized with heart failure. As an institution, you end up even spending more, which could have prevented initially when the patients came in. So this is what happens in the risk reduction of one decrease in the HbA1c. Of course, endpoints, microvascular is reduced by 37%, amputations by 43%, and all this is the science that Dr. Keli talked about. I don't want to go there. And this is where my discussion starts, understanding the cost of diabetes. So we have Barry and John, same age, but of course, different HbA1cs. And of course, you expect that John will have a better life. Why? Because the HbA1c is controlled. It's up to target. We're aiming at 6.5 to 7%. So of course, John will live long. He will live 60% longer without complications because of course, if you're well controlled, you don't progress to complications. And of course, John will spend 20% less than Barry because if Barry progresses to complications, progress to end-stage renal disease, retinopathy, neuropathy, heart failure, of course, he'll end up spending more, which he thought he's saving up because now this drug is this much. So let me use this and with the assumption that it works as well as this, only forgetting that in the long run, he'll actually spend more on the complications. Then we have how do you achieve cost effectiveness? What's the impact? And in this case, we have Elvis and George. So you look at this table and you can see and that is what costs more, the complication costs. So since Elvis is not well controlled, the blood sugars are high. So of course, HbA1c is 9.1 as compared to George. So complication costs for Elvis will be much higher as compared to George. So let's not always look at the direct cost of the drug. Let's look at the long run. What's the impact in the long run to this patient, to your patient? What do they save up patient if they initiated on the right medication? You know, so this is what this table is able to explain. And you can see for anyone who is well controlled because they initiated on the right medication and they agreed to stick to it, they'll actually do the person who says, let me have this, it's as good as this and I can manage to have on it, but they're not sure if it controls, it really controls their blood sugar. So what do you look for and what's the best value in diabetes? Of course, you look for something that will reduce the weight, have less episodes of hypoglycemia, and of course, reduction of HbA1c. And if you can get that, why not? That's a consideration that you'd want to offer to your patients. So basically, it's the same thing. This is the science about it. What's the impact in the reduction of the HbA1c? This was discussed by Dr. Keli, but I can still mention as an overview, when it comes to Jardiance 10, Jardiance 25, reduction of HbA1c as a monotherapy is higher as compared to combination. In the same case, what's the impact on all randomized Jardiance versus all comparators? And this is the impact that it has. Then let's talk about the values. So there's the price, there's the value, there's what you incur in terms of price, the distribution, the marketing, the research and development, the manufacturing, and what value, because you know that's a price that is factored in, and of course the various markets, and then there's the value that comes in. What value does the patient get? What does value that does the physician get, and what value does you as the payer in your various. So what is the value in healthcare? And we said that a patient health outcomes achieved relative to the cost of care. It is the value for the patient that is the central goal, not the value of the various, the other actors. The other actors is the physician and the payers. So what value does the patient get? Do you consider the outcome of treatment when making a drug decision? Do you consider the outcome of treatment when making your drug decision? So we had the EMPA-REG that Dr. Keli talked about. High-risk patients, 99% had all sorts of comorbidities. Maybe previous MI survived. That's, of course, an unfatal MI and unfatal stroke, you know, cardiovascular, any other cardiovascular disease that they have on top of their diabetes. And of course, this was the outcome, the 3-point MACE, the risk reduction of 14%. And you can see the impact on the patient who is on Jardiance 10 milligram. So the same thing when it comes to cardiovascular protection, which is broken down in cardiovascular death, hospitalization with heart failure, all-cause mortality. And this is what you look at. And when it comes to now, as you have seen in the guidelines, what do they consider as first-line treatment in the management of a diabetic patient with cardiovascular disease? And the consideration is, you know, SGLT2s, you know, and why? Because they offer more beyond controlling the blood sugar. Now we're looking, what other more benefits can you get? We are seeing on risk reduction of 38% hospitalization with heart failure, risk reduction with 35%, and all-cause mortality reduction with 32%. So all that summed up offers cardiovascular protection. And this is what also when it comes to new onset or worsening nephropathy, you can see the impact is immediate also when compared to placebo. In this case, placebo is standard care for this patient. So if there's 39%, which is above a third risk reduction, then of course this is a benefit to your patient. So this is a summary that gives you the benefits that come in when you have your patient. Quality of life improves, and of course we see how you save up on the costs of complication that comes to this patient. You know, costs that come in with administration, hospitalization, transport, because most of these are people from up country. So how much visits do they have to keep on doing to come see the doctor? And of course, if they're not well controlled, progressing to complications, they'll do as many visits. So that's a cost, you know, transportation, depending on what means they use. So a working person, they have to be off duty. So of course, there's a lot of pending work. So that's also a cost that is incurred by the company. Adverse event management costs. So there's too much cost incurred if the patient is not well controlled, and of course, progressing to complication. So how do we save it up? How do we save it up for the patient? How do we save it up for the payer? How do we save it up for the institution? And this is what I was talking about, the economic journey of diabetes. So we have two patients here. We have one patient who is put on Jardiance, 10 milligrams. And there's another patient who is put on the normal standard care, maybe metformin, sulfonylurea monthly. This is just an estimate. This is just interpret the whole information. So, you know, slips into hospitalization to heart failure, will experience a cost of W. The new onset or worsening nephropathy, because of course they're not well controlled, will incur that. The same thing happens with all-cause mortality and overall costs. And of course, in the long run, if maybe they're on something that triggers episodes of hypoglycemia, you of course, standard care will be much less in the long run over a duration of 12 years, a progressive disease. So diabetes being a progressive disease, initially when it starts, it's asymptomatic. Most of the time, by the patient is being diagnosed, symptoms have jetted in, and that tells you pole. The patient is also now experiencing some complications, which are sliding in slowly. But what about if you consider putting this patient on Jardiance? So, of course, they'll have less episodes or hospitalization with heart failure. Of course, you reduce the cost of new onset or worsening nephropathy, as you've seen, if they had a risk reduction of 39%. So this tells you that this patient will, you know, any cardiovascular disease and overall costs and hypoglycemic events. So they'll have more savings in the long run because so we talk about the CALI, quality adjusted life years, which evaluates the morbidity and the mortality. So this is a combination of the life expectancy, as you've seen, if a patient is diabetic or diabetic with cardiovascular disease, you're able to mitigate this. Then there's quality of life, good CALI. There's 1 year that translates to 1 year in perfect health. So evaluating cost and effects of intervention. This is where we talk about incremental cost effectiveness ratio, and it's been well defined in these statements. It's the difference between the new cost and the old cost divided of the new costs of management vis-a-vis the difference between the new cost and the old cost. So the outcomes of the new costs versus the old costs, and then the outcomes, the cost versus the outcomes divided by the outcomes is what gives you the incremental cost effectiveness ratio. And when comparing an intervention with other interventions, this is now where we are trying to compare. When you put a patient on, the patient is initiated on Jardiance, vis-a-vis the patient being initiated on standard care, vis-a-vis also a patient being initiated on maybe another SGLT21. what is the impact? What is the cost, incremental cost effectiveness ratio? Where do you end up saving up more as compared to where, you know, a patient thinks that they're saving up, but in the long run, they end up spending more. And shows you on your northeastern sides, if I've used it here at the northeastern aspect, where you have cost effectiveness and a more effective drug. Of course, you look at the direct costs, which you presume will be higher, but in the long run, it will be more cost effective for you as the payer, as an institution. Vis-a-vis, when you think that you'll use a lesser pricey drug, but look at what is the incremental cost. It will be much higher as compared to the incremental cost effective ratio threshold will be much lesser with a less effective drug as compared to the more effective drug, which will. So this is more of health economics, just to understand as a payer. So this is just a UK setting on how is Jardiance more cost effective as compared to any other SGLT2s and standard care. So there was an arm that was done for standard care. There was also another arm that was done for other SGLT2, but they didn't define which ones. It was just other as compared to Jardiance. So the life years, as you can see, for Jardiance were more as compared to standard care. So the incremental cost effectiveness ratio was and a patient on standard care, and also the quality of life. So you look at the direct cost. Of course, you look at the more as compared to standard care. It was maybe way less. And then the total cost on this arm, you'll see that when you include the event cost, the drug cost, the total cost, you'll tend to see that probably it will look more, but in the long run, the incremental cost effective ratio will be much higher as compared, will be much higher for the arm that was on Jardiance as compared to standard care. So that tells you it will save up more for the institution or the payer as compared to whereby the patient who is on standard care, because now when they start sliding in, you tend to spend more. So the incremental cost effectiveness ratio will be less for the patient on standard care versus the patient on Jardiance. And then there was an arm whereby the patient was on Jardiance, and then the other SGLT2s. So decided, let's take each group, similar number of patients. How much will I spend per patient on Jardiance? That will be 18,507 euros as compared to a patient who is on another SGLT2. So you see that the incremental costs will be, the difference comes to £1,064, but the total costs will actually be more on the patients who are on the other SGLT2s as compared to Jardiance. So you'll have a whole saving for your institution of 106,400 euros, which is equivalent to having 6 more patients on Jardiance. Only look at all the summed up costs that we've discussed, you know, the management costs, the complication costs, you know, the transportation costs, all that. So if you can be able to save up for institution, this comes in handy for the institutions that take care of their employees plus their dependents. So if you're in this institution, and of course you want to maximize and utilize the budget wisely to be able to spread out, especially on patients who are on chronic, on the right medication, and save yourself up for, you know, progression to complications costs. That will be way easier. It is a saving for you, and you can be able, and when you get those savings, of course, you can be able to channel them somewhere else, which will be beneficial to the institution. So this is basically what sums it up. You'll have more patients, similar budgets. So you have a budget of £1 million, 1 million euros, sorry. So you tend to have more patients who you can afford to put on Jardiance as compared to other SGLT2. So what's the budget impact and the cost effectiveness analysis? Budget impact model compared to compared the total cost of care for the whole population of interest, and a cost effectiveness model used by Markov patient level simulation produced average costs and benefits per patient. And this is what the outcome was done. It was basically also done on the EMPA-REG just to see. You see, you have patients already who had complications due to uncontrolled blood sugar, of course, the diabetes. So the non-fatal MI patient who had diabetes with non-fatal MI, previous non-fatal MI, hospitalization due to heart failure, renal failure and all that. So for each event, clinical rates were extracted from the EMPA-REG. These were high-risk patients. You remember 99% of our patients were high risk. So of course they had maybe experienced an unfatal MI, unfatal stroke, peripheral arterial disease, coronary arterial disease, heart failure, and all those. So what's the impact of Jardiance on healthcare budgets? So depending on the balances of saving, as down here in South Africa, which is in Africa basically, it shows budget to be able to take care of the cost of the drug. They're able to save up 319 deaths were avoided. So that tells you if you can actually be able to save lives and improve quality of life, that's what you're looking at. Of course, your budget will slightly increase, but you see you're able to save life. You're able, to avoid 319 deaths, which is a plus, and that's what you're looking at. You improve on the quality of life of this patient. The life expectancy increases way 6 years back, but you see if they're initiated on Jardiance, and the institution, the public institution in South Africa was able, to prevent that death of that patient. That's a plus. And you see also there's no workforce lost if it's a working person. So it also saves up on that. So in summary, we've seen the benefits of Jardiance, of course, in cardiovascular protection, in risk reduction of cardiovascular death by 38%, risk reduction of hospitalization with heart failure by 35%, and all-cause mortality by 32%, and of course, the 3-point MACE by 14%. So that's actually a plus. That's something you'd want to consider having your patient on, and you've seen, saving up on costs of this patient who is diabetic with cardiovascular disease. Why don't you have this patient, initiated on the right medication to improve or increase their life expectancy? So in several countries, you've seen Netherlands and South Africa, Jardiance showed a cost neutral or cost saving. And even in addition to that, it was also to prevent, the number of deaths that they would have experienced, which is also very expensive. And in other countries, Jardiance increased budgets, but also provided great value for money with low incremental costs effectiveness ratio, as we've seen. So Jardiance comes in two strengths. We have the 10 milligram, which is given once daily, and the 25. The default dosage, that 25, if you feel the HbA1c is not going down. Of course, not majority of patients experience that. And for Jardiance, of course, you have to do the renal function test to just be sure what's the EGFR levels of the patient. If they're above 60, you can initiating. We do not recommend. So we recommend that you initiate above 60. As we've said, diabetes is a progressive disease. So if the renal function is declining, if it gets to below 45, for now, we recommend at any time of the day because it's once daily, can be used in combination, as you saw in a table that I did. But of course, as a monotherapy. And basically, I've summarized everything about Jardiance. It's an oral agent available. It's shown the evidence, cardiovascular protection, which are excellent. Heart failure, kidney benefits. It's effective. Apart from just reducing the HbA1c, it has been shown to reduce body weight. Also, if the patient is hypertensive, there's evidence that has shown it reduces the blood pressure with 4 millimeters of mercury, which is a plus, but it's not an antihypertensive. It's just the benefit that comes. Anti-diabetic drug, has very low risk of hypoglycemia, and provides excellent clinical and economic value. Thank you.
Thank you so very much, Miriam. We go directly to the question and answer. Dr. Florence, are you with us? Hello, Miriam, can you hear me?
I am. Yes, I am.
I can hear you.
Okay, so the first question is, what is the cause in the increase in bone fractures from the studies? That comes from the question from Dr. Lillinger. Okay.
Yes, there is no explanation as to why fractures do occur with the use of SGLT2. As it were, there's no reason yet, but they do occur with certain SGLT2 inhibitors.
Wonderful. The next question is from Teresa Wahome. First, does empagliflozin require dose adjusting for patients undergoing dialysis? Second, what is the ceiling dose for empagliflozin?
Okay, this is a question best answered by the nephrologist, but I will try. You can use empagliflozin, Jardiance, in patients who have got an eGFR up to 18. Beyond that, in the trials that exist, not recommended. And those are the patients that will be going dialysis, undergoing dialysis. Actually, even the ones with a eGFR of 18, you can use. Why do we use it in a ceiling of eGFR of 18 and upwards? It's because of the other added advantages of empagliflozin. What are these advantages? It reduces the risk of hospitalization for heart failure and time of stay in the hospital if you have heart failure. Can be used to manage heart failure in regards, that is, depletes volume in summary. And then it has other cardiovascular benefits, reduces death and risk of non-fatal myocardial infarction and stroke. That's why we will use it over and above a patient who has got an eGFR of 18. And that's a patient who is going to be dialyzing. So we can use it, but not beyond 18.
Asante, a question from esteemed colleague, Dr. Anthony Kodiwo. He asked, kindly comment on the potential carcinogenicity for both SGLT2 inhibitors and DPP4 inhibitors. Is this a class effect or does it only apply to individual agents? If only individual agents, then how do the agents compare to each other with respect to this?
Okay, these are two groups of drugs. SGLT2, let's go to SGLT2 inhibitors. The adverse events of SGLT2 inhibitors that we worry about first, the one that are very significant, is the bone fractures, which we do not know why patients tend to have bone fractures. However, you do realize that the trials of these drugs were in patients who are more than 65 years old, and there was no evaluation for the risk of osteoporosis. So it could be, these are patients who are also having osteopenia, so a tendency to have fractures then is high because they already have the risk of osteopenia, but it's not yet, that is my reasoning. The other adverse event of SGLT2 inhibitors is genital and urinary tract infection. That is a class effect because when you cause urine to have glucose, then that's a media for bacteria to thrive. It's glucose. Okay. DPP4 SGLT2 inhibitors don't cause cancer. That is in relation to bone cancer. DPP4 inhibitors, because of the incretin, the mode of action in regards to incretins, they do not cause pancreatic cancer, neither do they increase the risk of pancreatitis. But in a patient who has suffered pancreatitis before, you want to be cautious when you are giving DPP-4 inhibitors. Next. And then for DPP-4, wait, I need to say something. For DPP-4 inhibitors, remember linagliptin, which is of Boehringer Ingelheim, does not, even though it is an incretin-based therapy, does not in any way, it has advantages in regards to you can use it in patients with end-stage renal disease because it has hepatic elimination. Next.
Wonderful. Miriam, are you there with us?
I'm here. Bow.
There's a question on Jardiance contains a carcinogenic product as per an FDA report that has been released today. In fact, the anonymous attendee goes ahead and shares the article on the Daily Nation. It has, it's not Jardiance. The anonymous attendee shares it is from Geneva. Are you able to comment on anything, on any data you're having on your end from in regards to Jardiance?
I'm not aware of any carcinogenic material with Jardiance that has been reported, nor have I seen. Is the carcinogenic stuff on Jardiance or on our products?
It is on Geneva.
No, I can't report on Januvia.
I will take that. Let me take that. Januvia is sitagliptin, which is a DPP-4 inhibitor. And today we are talking about SGLT2s. Maybe if we were privy to that discussion, would comment. We need to dig it further and see what are the reports saying in Kenya. Maybe in Kenya, because we are a different race. And remember, in some of these trials, the DPP-4 trials that I showed examine and all the rest, we did not participate, yet we used Januvia. And actually, we do not even have a brand Januvia in the country. I think we have a different brand altogether, but it's still sitagliptin. So maybe when we engage with the article, we'll be able to see what the observations have been locally. Today, we are talking about SGLT2 inhibitors, but because I mentioned the other drugs, I'll take any question in regards to that.
Asante, thank you so very much, Dr. First and foremost, allow me to recognize the presence of respected seniors in the profession. We have the chair of HOPAC joining us today, that is Dr. Hilary Kagwa, who also wishes to welcome us to attend the HOPAC conference that shall be taking place in Eldoret this year. The HOPAC conference shall be taking place on October, from the 14th and 15th of October. And also, he reminds us that the submission for abstracts is ongoing till the 15th of September. Also, allow me to recognize the presence of our respected senior, Dr. Peter Ongwae. Also, allow me to recognize the presence of our respected senior, Dr. Arti Kamau, and also Dr. Alfred Birishi, Dr. Albert Ndwiga, and the CEO KHF, another than Dr. Anastasia Dalita. So, Miriam, what is your parting shot for tonight?
Repeat your question again.
What is your parting shot tonight, Miriam?
Thank you, Bao. My parting shot tonight is, it is my prayer that you recommend the benefits that you've learned of Jardiance, both on science and on the value to your patients for the betterment of you as the payer and as the institution, to save up on your budgets and to be able to, improve the life expectancy and quality of life of your patients. That's my parting shot.
Wonderful. Dr. Florence, are you able to give us a parting shot at this moment?
Yes, I will.
Okay, Dr. go ahead.
In regards to SGLT2 inhibitors, I know there is 1,000 in the market. There are some subtle differences between each. Again, and that is for you to go and check, because if I start talking about them, we'll go into the evening and we'll not have your ugalis. Number two, I only say this. If you want to manage a case, what is the best option available? Is there an original brand? because you are sure the original brand is the one that caused the effects we've talked about. Reduced cardiovascular mortality, reduce the risk of non-fatal stroke and non-fatal myocardial infarction. And remember, when a patient suffers a non-fatal myocardial infarction, that is, they have an MI and they are living, their risk of another MI is much higher. When they suffer a non-fatal stroke, likewise. And of course, if a patient has suffered a stroke, their life is never the same. Remember, Miriam talked about quality of life and cost of care. Patients who have suffered myocardial infarction or stroke that was non-fatal cannot be said to be incurring the same cost as people who are normal or have not suffered these two. So always factor that. And for you to get the best of this, the intervention that is in existence, always go for the brand, because you are sure I'm going to be reducing the risk of cardiovascular events by this much, because the drug is the one that was tried. Thank you, Mbao.
Thank you so very much thank you so very much, Dr. Florence, from PSK, from the President PSK, Dr. Louis Mashogu, from the PSK CEO, Dr. Lucas Jebero, and the National Executive Committee, National Governing Council at large. They would wish to say thank you so very much for taking your time to even prepare this well-detailed presentation for our members. Again, once again, thank you so very much, Miriam, for partnering with us and for your continuous support towards capacity building of the Kenyan pharmacist. It is in this juncture probably we need to consider Miriam as a honorary member of PSK by ensuring that you've continuously provided us with great capacity building meetings as such to ensure that we not only are up to date, but are internationally up to date with the latest guidelines in matters diabetes. Ladies and gentlemen, without further much ado, we are almost coming to the close. I have shared a link on the chat box. Kindly click on that link to ensure that we are able to assist Boehringer Ingelheim, as Miriam said it best. We're able to assist them in ensuring that they are able to get the best presentations, they're able to get the best output from our meetings. The other thing is to announce is that we are going to have the World Pharmacist Day presentations and training on MTM. I do hope that majority of those who are here have registered, and if you've not registered, I suggest that you register for the MTM training, whereby we're going to also increase on our knowledge and capacity as a profession. Ama kweli lilo na mwanzo lazima liwe na mwisho. Tumefika katika somo letu la leo. Tunawarudishia shukrani zangu za dhati wasikilizaji wetu wote wa leo. Tunasema asante kwa kujiunga nasi. Tunabudi ila kusema kwamba juma lijalo tutakuwa na somo lingine, na tutajitahidi zaidi tuweze kuongeza masomo yetu ambayo yanafanyika katika huu mtandao wa Zoom. Wahenga hawakutupaka mafuta kwa mgongo waliponena kwamba lilo na mwanzo lazima liwe na mwisho. Sina budi la kuaga. Alamsiki.
Thank you, Mbao. Have a good evening.
For those asking for the Karibu Sandatari, for those asking for the presentation, I have shared the PSK YouTube page. That is where you're going to get the presentation. It's going to be shared. This whole meeting shall be shared on our YouTube page. Asanteni, muwe na jioni njema.
Good night.
Hey, Dr. Florence, you can end the meeting. You're the host.